Thanks for tuning in to Watson Clinic Health Talk. According to the American Cancer Society, there is a 1 in 8 chance that a woman in the U.S. will develop breast cancer in her lifetime. It's the most common form of cancer to afflict women, second only to skin cancer. But there is good news. Mortality rates have substantially decreased in recent years because more women are getting their mammograms. In honor of Breast Cancer Awareness Month, we've brought in the ideal guest, Dr. Elisabeth Dupont. She's a board-certified breast surgeon who treats patients from Suite B of the Watson Clinic Women's Center at 1400 Lakeland Hills Boulevard in Lakeland. And she's also the medical director of Breast Health Services at Watson Clinic. During this conversation, we discuss the importance of early detection, the latest advancements in treatment and surgical approaches, and the services Watson Clinic offers in the category of breast health, from mammograms to breast surgery to plastic and reconstructive surgery. For more information on our comprehensive roster of breast health services, visit watsonclinic.com/breasthealth. Dr. Dupont, thank you so much for coming in and joining us today.
It's my privilege.
Breast Cancer Awareness Month. You're busy all year round, but this month must be particularly crazy for you.
It is. It brings out everybody that hasn't had a mammogram in a while. They get a reminder. They go, oh, yeah, I really need to do something. I need to take a look at something I've been watching. And we do see an uptake in diagnosis during this time.
And speaking of breast cancer awareness, this is a campaign that over the years and decades has really made a positive impact.
It has, because it's led to more self-breast awareness. In the past, women didn't talk about this. Say in the 60s and 70s, women didn't talk about breast cancer, and it wasn't the word cancer that was the difficulty, it was the word breast. So historically, the word breast was kind of a taboo, and women didn't even talk about it, even when they started talking about the need for, say, deodorant. The word breast was kind of a problem, and they could talk about cancer, but not necessarily breast cancer.
Oh, that's interesting. So in terms of changing attitudes and awareness out there, not only that, but also the technologies in detection and treatment, what have you noticed in terms of the advancements just since you've been practicing medicine?
Well, the biggest thing, I think, is how we handle lymph nodes. The lymph node evaluation has changed significantly. When I was early on at Moffitt, we were still doing as standard of care a complete node dissection. In other words, taking out all of the lymph nodes from underneath the arm, whether or not we knew there was any cancer there. And as we got better at diagnosing the tumors, there was less cancer. So they had a lot of people who probably got a big operation they didn't need, and the side effects from that. With the advent of sentinel node biopsy, we became more specific at what we needed to take out to assess the situation. And then became the other studies to say, okay, maybe we have a little bit of tumor here in one of the lymph nodes. Do we really need to do chemotherapy? Do we really need to take out more lymph nodes? And now we're selectively taking out more lymph nodes in a small number of patients just because of the nodal burden of the disease.
Right. And I would imagine that therapies have become a lot more targeted.
They have, a lot more targeted. That was mostly in the realm of systemic therapy, which is for the whole body, not local therapy. Although radiation is more selectively targeted now too, I think. So the systemic therapy is very important to the overall outlook, prognosis, and survival of the patient, probably more so than surgery. So having targeted therapies that will specifically go after a certain receptor in the breast tissue or breast cancer is very important and helps to decrease side effects and improve survival.
We're going to delve into breast surgery.
Okay.
Your area of expertise. But first of all, let's give people a kind of a primer on the current state of mammography. First of all, the guidelines. When should people be screened?
Well, there's been a lot of controversy of that, and there was some change back a few years ago saying that women should be over the age of 45 to start. And what we found out was that was incorrect in a large population. Our African American women probably needed to start sooner. So now I think, in fact, overall, the guidelines are saying that age 40. Or if you have a relative that's had a breast cancer, you need to start 10 years younger than that closest relative who was diagnosed. So if mom had a breast cancer diagnosed at 45, you need to start at 35 with your mammograms and screening.
Okay.
So it's more patient specific.
And it's first generation or its closest relative?
Yeah, it's primary first degree relative, such as mother, sister, father's sister would be in there and be very important too, because the father's side of the family is also very important. So if dad had 3 sisters that were diagnosed with breast cancer, that's an issue.
Once a year?
It depends. Now, if you're tested and you have a genetic defect and you're trying to figure out when you're going to have your surgery, then you might need to have surveillance more than once a year.
Okay.
But otherwise, generally once a year.
And it doesn't matter how old you are?
In my opinion, no.
Okay.
I've had days we haven't operated on anybody under 90.
Interesting.
The disease is one of females getting older. My oldest patient was 102, and my youngest was 21, and everything in between. But the older we get, the higher our risk of breast cancer. So in my opinion, if you're 85 years old and you're out there playing golf, you're getting your mammogram.
For those who have not yet had a mammogram, what can they expect from the experience? What does it entail?
Well, if you haven't had a mammogram, it is important to understand that they might briefly be a little bit uncomfortable, because the more compression you have, the better the pictures and the less radiation you get. So the compression is necessary to help to make sure that we're smoothing out the breast and that we're not having a bunch of tissue on top of each other that might artificially look like a lump. So a little bit of compression, but it only lasts for about 8 seconds. You're going to be in the room with the technologist the whole time. The technologist will position you in multiple ways, and the experience is generally over in about 15 minutes. So it's very quick. Now, if you have fibromyalgia or something related to that, you might want to take some Motrin, Aleve, Advil, something like that, if you can, if your doctor will allow it beforehand, because it will help you to tolerate the compression a little bit better. Sometimes you can even ask for a pad, and if it's appropriate, they can give you a pad to put on the machine. But it's a quick experience, and the discomfort doesn't last that long.
And if an area of suspicion or concern is detected on one of those mammograms, it's not an automatic reason to worry.
Right. Most of the time it's not. Most of the time it's just a collection of tissue that has kind of not been smoothed out enough, and that collection of tissue can artificially look like something. Even if you're called to do a biopsy, most of the time it's not cancer. And lots of times there's things that look like a cancer, that look kind of bad on a mammogram, but are totally benign, and we can just watch those.
Okay. How important is it to know your breasts, to do those kind of self-checks every once in a while?
It is, and I'm glad you didn't use the word exam, because
Right.
we don't like to use that anymore because people get nervous about flunking an exam. So
Right.
It's self-breast awareness. And that's very important, because if you have been following your own self-breast exam and you know your lumps and bumps, if you find something, it's going to be found much earlier than if you just stumble on it because you tripped over the cat and all of a sudden you have a sore spot on your breast. Mm-hmm. So it's very important to be self-breast aware.
And we were talking about some advancements earlier in terms of the detection, the advancements in detection. and diagnosis, we utilize 3D mammography.
Yeah.
And that's highly perceptive.
It is. It's almost like a CT scan for your breast in many ways, because it takes a movie of the breast and that kind of smooths through the tissues, and you can really see what's going on much better with a 3D mammogram. And we've been doing this here since about 2012, I think. So we were a very early adopter of 3D mammogram because it's so important. Sometimes MRI is important. A lot of radiologists do like the MRI. It's a very sensitive test, but not very specific. So it will show up a lot of things, and you might need to have an ultrasound after that. The ultrasound is very good for determining if a lump is a cyst or a solid lesion. In younger women, the ultrasound can be extremely helpful. There is on the horizon something called contrast-enhanced mammography, where you get a contrast injection and then take a picture, do a mammogram. And I'm hoping one day insurance will see the value of that and start to cover it, because it will help us to detect more cancers.
Is that already something that's out there, just hasn't become widespread yet?
It is. At academic institutions, say
Okay.
MD Anderson in Houston, that kind of thing, they have them, and it's pretty common. But it's not very much covered by insurance, and it's going to take a while to get that through.
So a point of suspicion is found on a mammogram. What are the next steps?
Well, they'll be called back for maybe additional views, compression views, angled views, to see if what they suspect is something to be biopsied is a real thing. You might also have an ultrasound, and the ultrasound will help further define it and see if they can see it under ultrasound, because then the biopsy is a little bit easier on the patient.
Okay.
Sometimes they have to be biopsied under stereo, and sometimes even under MRI situations. But ultrasound would be much more comfortable than any of the others. So you get through that and you get your diagnosis, and then you come see a surgeon, and the surgeon will walk you through the next steps. Sometimes it's going to surgery and getting it out. Sometimes it's going to chemotherapy because of the different personality of the cancer. The personality of the cancer drives what we do with it these days. Cancers are like children. You can have a set of kindergartners, and you can have a small little red-headed boy who knocks over mailboxes with a baseball bat and catches cats by the tail. Very, very tall girl who picks up the toys on the playground, wants to be the teacher's pet, and everything in between. And the large girl is kind and gentle, even though she's large, where the little one is small and kind of disasterly. And so the chemotherapy is designed to go after that small lesion, because it's a naughty lesion, and will tame it and have a better outcome. So you can't just say it's a ductal cancer. You have to look at the personality of the cancer, just like you do children.
Well, a lot of, particularly surgical oncology fields, have benefited from this new era of genetics, DNA, where you could prescribe very specifically the kind of situation that's going on with each individual patient.
It's really true. And in breast cancer, I think the biggest advantage has been with the HER2 tumors. HER2 is a receptor that sits on cells, and you have them on some breast cancer cells in abundance. And that means it's HER2 positive. Positive in medicine means the presence of something. Negative means the absence of something. And so when you have an abundance of these HER2 receptors, then the coding for the division of the cells goes haywire and cancers are made. We now have medicine that comes in and binds with those receptors and turns them off specifically. Back in 1998, when I first knew about HER2 and we were learning about it and had medicine that was prescribed for it, we were only giving it to those patients that the cat was out of the bag and they had distant disease. And they did so well that they thought, well, why wait for that to happen? Let's give it to people before the cat's out of the bag. And then now we give it before surgery because it works so well. And there are additional drugs now that we have discovered, in addition to the Herceptin, that helps to really shrink the tumor. And sometimes when we go in and do surgery, the tumor is pretty much gone, which is a really important thing for the patient because they know how well everything has worked.
Yeah, so I would imagine that's not only detection rates and the rates of people that are aware of the dangers of breast cancer and the importance of early detection, but the survivorship rates have probably benefited a lot in the past years as well.
We have really done well with survivorship. It has improved, and the overall survivorship for breast cancer is now in the 80+%. And in some cases, it's in the 90+%. And that is benefited by the work of having targeted therapies like the Herceptin. And we have genomic profiling, which again leads to the personality of the tumor. And the genomic profiling will dial down on the different aspects of the tumor and help us to determine who would benefit from chemo and who would not benefit from chemo.
It's interesting, just the evolution of all things, but particularly in medicine. I mean, but we had to start from that place many years ago to get to where we are today, because our understanding has deepened over the decades.
Tremendously, over the decades, over the century. To think that back in 1910, the standard of care was a radical mastectomy where you took out the muscle, the nerves, and all of the lymph nodes. And now we have gone to where we can do a lumpectomy, and sometimes we know that radiation is not even necessary. And a lot of that is because of the improvements in systemic therapy as well. But we have become much less radical, and that's very important.
And in terms of radiation chemotherapy, we have those services that we can direct patients to at our Cancer and Research Center. We have an in-house plastic surgery capability where you work in tangent with our plastic and reconstructive surgeons.
It's very important to me to have plastic surgeons that are willing to help the patient restore their look and have a more normal looking outcome. I work with our plastic surgeons at the clinic. Drs. Ferguson and Casimir are a great asset to my program. They will sometimes come in and after a lumpectomy and modify the breast tissue, rearrange it to fill in the space so the defect is not even noticeable. And oftentimes the lady looks better than she did before surgery because they can get a nice lift out of it, and symmetrical surgery on the other side. The advent of oncoplastic surgery has been so important to the emotional outlook of these patients because they no longer have to worry about being deformed like we did so many years ago.
I just attended an interview that you conducted with the media last week, and a common topic this time of year, what are the common myths about breast cancer? And I heard you say something about when you get a mastectomy as a preventive measure, that doesn't necessarily eliminate your risk of developing breast cancer.
We can't bring your risk to zero as much as we'd like to. Now, if you have the gene, having mastectomy both sides does reduce your risk by 90+%, but it doesn't reduce it to zero. As long as you've got skin, you've got breast tissue. And as long as you've got breast tissue, you are at risk for having a problem. And I've seen it. I've seen patients that had a mastectomy 20 years ago after having cancer on both sides, and now something's back after 20 years with the mastectomy. And that's because as long as you've got skin, you've got breast tissue. So when people say, I want them both off because I never want to do this again, I have to correct them and say, that is a myth. That is false, because we cannot eliminate totally your risk.
Are there other common myths that you want to dispel today?
Oh, yeah, there are several. One of them is that cancer has to hurt. Cancer in the breast definitely, usually does not hurt. And it's the lesion that's painful that is less worrisome, in my opinion. So that is one. One of them is that, well, I don't have to worry because it's only on my father's side. Well, dad's side of the family is equally important as mother's side of the family. So, for example, like we said before, if dad's 3 sisters had breast cancer, you may have a gene. And then that's the other myth, that if you don't have the gene or if you don't have a family history, you can't get it. Not true. Most of my patients do not have a family history of breast cancer. And it is only about 20 to 30% that do have a significant family history. And so everybody has to be aware. Everybody has to be diligent, and everybody has to have their mammogram, whether or not they think they're prone to it. Every day I hear, well, I never thought this could happen to me. Unfortunately, they've got the risk factors, and that's not always genetic. Risk factors, for example, are being female, getting older, weight gain of more than 25 pounds since high school, lack of exercise, a smoking history we now know can lead to breast cancer, and alcohol, unfortunately, can lead to breast cancer because alcohol metabolizes into estrogen. And that is what feeds a lot of breast cancers.
That's good information. And also, being male doesn't make you immune to breast cancer either.
You're right. I saw 2 men last month with breast cancer. And men can get breast cancer. They're just not aware, so we find it a little bit later than we usually do for ladies. But the men can get breast cancer. And when men in the family have a breast cancer, we have to look at genetics because it can very often be genetically predisposed, I should say. So yes, it's important to know dad's side of the family and know whether there's any men in the family.
So is there anything that you could do to help reduce your risk of developing breast cancer?
There are a few things that you can do. You can't eliminate it, but you can reduce your risk. And one of them is to eat a colorful plate. 5 to 9 fruits and vegetables a day would be important. Don't go on some crazy diet that is the new fad. Stop smoking, watch your alcohol intake, and most importantly, and my patients know I drum this in, exercise, move. You have to move. Exercise is really important to reducing your risk of breast cancer, prostate cancer if you're a gentleman, colon cancer, ovarian cancer. There's about 7 cancers. Pancreatic cancer it'll help you to reduce your risk of. It's very important. It's so important that some institutions have a division now called exercise oncology. And exercise is promoted to help patients get through their treatment, enhance their treatment. It is vastly important. I had a patient who was very young when she was diagnosed, and she was actually breastfeeding when she found her very large 9-centimeter tumor. And she had a very difficult tumor that probably the cat was out of the bag when it was diagnosed. And she exercised. She rode her bicycle to therapy. She participated in bicycle events. And she survived 9 years when I don't think she should have if she hadn't exercised. Not that she wasn't allowed to survive, but it's just that the disease was such that I was very surprised at how long she was able to keep it at bay. And it was exercise.
Those are such gold standards for every aspect of health.
It is. You'll hear this from all of your doctors if you listen.
Yeah. So listen out there. How long have you been doing this?
I've been here for almost 20 years in Watson Clinic in Lakeland. Yeah. In January, I will have been here for 20 years.
And then prior to that,
I started breast-only practice in about 1998 at Moffitt, when I was at Moffitt. And it's evolved significantly since then.
I would imagine. So during that time, I mean, you've seen countless patients at probably among the most difficult moments of their lives. The scariest, they're riddled with kind of uncertainty. What have you observed about what kind of information they want to know most commonly, and what they need from you, both in terms of your obvious expertise, but also emotionally, support-wise?
It's a very vulnerable time. We know from studies, again, when I was at Moffitt, that breast cancer is the second most traumatic life event. And when we ask a group of ladies, where would you put this in a hierarchy of events? House burning down, divorce, death of a spouse, and only the loss of a child topped a breast cancer diagnosis. And you can tell somebody, a lady, that I'm sorry, you've got a colon cancer, and they'll go, okay, what do we do next? You can tell them, well, it's you've got a breast cyst, and she is off the chain being anxious. So we know this is a very emotionally filled, anxious time, and that's because of all the myths out there, all the trauma that women used to have to go through back in this 1910s through 1980s. Lots of physical trauma during that time, and I think that's carried forward. So women are very concerned about being deformed, things being painful, and about surviving. And so what we need to tell them is that you are very likely going to survive this disease, and we are going to treat you like a lady. We are not going to deform you. We are going to treat you with compassion, and we are going to get you through this. And we're going to do as little as we have to conquer the disease, because the disease is not going to win.
Well, you're so fantastic at what you do. You are such a blessing to this community. And
my privilege to work with everybody.
Absolutely. And you're a blessing to this podcast.
Thank you. This has been a lot of fun.
Thank you for being our guest.
My privilege.
That's it for this episode of Watson Clinic Health Talk. To schedule your mammogram, please call 863-680-7755, option 3, and visit watsonclinic.com/breasthealth for more information on our roster of breast health services. Thanks for listening.